Okay, here it is, the much anticipated chapter 52. Sorry that it's a little late, but here it is. So chapter 52 is the last half of endocrine. So we spent a lot of time and a lot of energy. I think it was just one chapter, but a lot of energy talking about diabetes, just because diabetes is part of the endocrine system, and it's the most common by a long shot of any of the other endocrine problems. However, there's a lot of other endocrine problems that I need to tell you about and how to manage them as a nurse. So, chapter 52 is the rest of the endocrine system, everything not including the pancreas. So basically, the endocrine system has everything to do with hormones. And just like insulin is a hormone, everything in the endocrine system either they are either stimulated by a hormone, they release the hormones, and what a hormone does is it stimulates something else somewhere in the body to do something. So the problem in the endocrine system comes in if you have too much of something that is stimulated or stored, or not enough of something that's stimulated or stored. It affects everything else. So I drew a little diagram here. And so we're going to go through this diagram and we're going to talk about all of the different endocrine glands in the body and kind of what they do. So we're going to start up here in the brain. In the brain, you basically have three areas that are responsible for hormones or endocrine stuff. Two of them we're not going to spend a lot of time talking about. The first thing I want to point out is this little itty bitty pineal gland. There's a little tiny pineal gland. It is part of the endocrine system. All of the endocrine system is part of the autonomic nervous system. You can't control any of this stuff. No matter how much you try, you can't control if your body's secreting, thyroid stimulating hormone or something like that. So it's all part of the autonomic nervous system. The pineal gland, actually nobody's even really quite sure what it does. They're still doing quite a bit of studies about it. It does release melatonin, and melatonin is that thing that helps you go to sleep. They're also finding that it releases some hormones that make you feel good. It's associated with orgasms. It's associated with social interactions. It's associated with like maternal bonding and things like that. So kind of some vague stuff, tiny little gland. Just kind of know in the back of your head that there is an endocrine organ in your brain called the pineal gland. For sure it releases melatonin. Studies are out there about what else it does. Okay, so we're going to kind of set this one aside. Then your hypothalamus. I'm sure you've heard of your hypothalamus. That is a major structure in your brain. The hypothalamus is also responsible for a number of other things. We're going to spend a lot more time talking about it when we go over the neurosystem. Again, regulated by the autonomic nervous system. Fever, temperature control occurs in the hypothalamus. But it's also responsible for a lot of the fight or flight response. So it either stimulates stuff or it slows things down. The one thing that I do want you to remember in the endocrine system related to the hypothalamus is that it produces oxytocin. Oxytocin is a hormone that both men and women have it, but it is released a lot right after a woman gives birth, and so as the uterus gets rid or empties the fetus, then there's this release of oxytocin. Oxytocin then stimulates breast milk production. It stimulates uterine contraction. It helps the uterus to stop bleeding. So that's a lot of what oxytocin does. Oxytocin is produced in the hypothalamus, but it's stored over in the pituitary gland. So it's made here, stored here, but it acts on the pituitary gland. The other thing that the hypothalamus does that you need to remember is that it affects the pituitary gland, and it does that by either stimulating it or inhibiting it, depending on if it's in a fight or a flight response. So the things you need to remember about hypothalamus: it's in the brain. It does a lot of other things besides endocrine, but its endocrine function is to store the oxytocin, and then the oxytocin then will stimulate the pituitary gland in the event of, you know, baby being born, or, you know, lactation, things like that. And it stimulates or inhibits the pituitary gland. So now I want to talk about the pituitary gland. The pituitary gland is this organ that sits right up underneath the brain. And actually, people that have problems with their pituitary gland, they can have surgery, and they can have what's called a transsphenoidal, Phenoidal, phenoidal approach, meaning they go up through the nose, and you can hit the pituitary gland right, it's right about here. Like if you were to go into the brain right about there, that's where the pituitary gland is. And it's called a transsphenoidal approach. It's through the nose, but it goes right up here into the pituitary gland. So the things that act on the pituitary gland are the neurotransmitters. You have a whole bunch of neurotransmitters, and stimulation from the hypothalamus. So these two things come in and stimulate the pituitary gland. This is where the endocrine system gets a little bit confusing, because everything kind of stimulates and acts on something else. So you have to have a lot of layers of things in place for all of these to be acting as you would expect them to act. So if any one of these things gets screwed up, or has a malfunction, or gets cancer, something, or an abnormality in it, then whatever it's supposed to be doing doesn't work well. That's why it's important for you to understand what all of these organs actually do. So back to the pituitary gland. In the front, you have an anterior pituitary, meaning the front. It's anterior is this way, and the posterior is in the back. So your pituitary gland is basically cut into two halves like this. This is your anterior, and this is your posterior. The anterior part of the pituitary gland is really responsible for a lot of female stimulating hormones. So you've got things like your FSH, your follicle stimulating hormone, your lactating hormone is in there, your prolactin. You'll go over a lot of that stuff when you go into OB, but I'm sure you've heard that before when you were in physiology or pathophys. So it does all of like the female stuff, but men have those same hormones too, they just don't have as much of it. Plus, the anterior pituitary is responsible for ACTH, and ACTH is the adrenocorticotropic hormone. ACTH, adrenal corticotropic hormone. TSH, thyroid stimulating hormone, and GH, which is your growth hormone. So the front of the pituitary releases all of these things, and all of these things are additional hormones that tell the body to do different things. I want you to remember that your ACTH, adrenocorticothyroid hormone, is responsible. When this becomes abnormal, that leads to Cushing's disease. So, and we're gonna talk about that in a minute. Just keep in mind your ACTH, adrenocorticothyroid hormone, is responsible for Cushing's. The thyroid stimulating hormone, the whole point of that hormone is to go down here and stimulate the thyroid gland. Okay? So, and we're going to come back to that in a minute. I want to finish up with the pituitary stuff. So that's what the anterior pituitary does. The female hormones, thyroid stimulating, or follicle stimulating hormone. What else did I say? FSH, LH, lactating hormone. Yeah, that's it. So your female stuff, ACTH, TSH, and GH, anterior pituitary. Posterior to pituitary now has your antidiuretic hormone, and I know you've heard this before because we talked a lot about it when we were talking about fluid and electrolytes. ADH, anti-diuretic hormone, and that then has, as you know, has a lot to do with the kidneys because it stimulates how much fluid is retained or lost. Vasopressin and oxytocin. Oxytocin is another hormone that stimulates milk production and uterine contractions and things like that. But men also have oxytocin. Oxytocin, well, I'll tell you a little bit about that later. So anyway, so pituitary gland, anterior stuff, posterior stuff. You need to just kind of keep in mind, you're probably not going to get a specific question about, like the ADH and the posterior pituitary. You just have to kind of remember that your ADH is posterior pituitary, TSH is I didn't mean posterior, I just meant pituitary. TSH is pituitary, GH comes from your pituitary gland. It's really, unless you're going to work in the endocrine system, endocrine field, you probably don't need to know anterior, posterior. But it's just helpful to know which hormones are coming out of the pituitary gland. Because you can have a lot of problems with your pituitary gland, and if you have to have surgery on the pituitary gland, then you just need to be cognizant if your patient is coming back from the operating room just having had pituitary surgery. And I think there's a thing in your book. I looked through this chapter. I'm 99% sure there's somewhere in here that shows you the different approaches to surgery. Maybe not. Am I lying? Maybe I lied. I guess not. I thought I saw a picture of like a transphenoidal approach to a pituitary tumor, but I guess not. Whatever. Anyways, it's either transphenoidal, they'll go up through the nose, or they can do neurosurgery and cut the part of the skull to go in and get it, but that's not super uncommon to have like a pituitary tumor, growing that and then needs to be removed. And following the surgery of that, then you watch for like some diabetes insipidus or some other problems that might be associated with ADH or thyroid stimulating hormone or ACTH. So that's why you have to be aware of what hormones are going on in there. Okay, so that's the pituitary gland. Now, the other thing that you need to know that we'll talk about sort of in the pituitary section is what happens if you have too much production of these things or not enough. Because you can have a hyperactive pituitary gland or a hypoactive pituitary gland. When you have, let me see what page I'm on here. When you have too much release of pituitary hormones, that can lead to Cushing syndrome. And Cushing syndrome, and it gets a little complicated, but you have an increase of TSH that stimulates the thyroid hormones. That produces the release of these hormones, leading to an increase in hormone production down in the cortical system, and then you have Cushing's disease. Or you can have the other things that can happen, because if that growth hormone gets stimulated, and it just makes sense, if your growth hormone is stimulated, you start growing. And so it's rare, but like giantism, like people that are just ginormous, like giant people, have overstimulated pituitary glands because it's overstimulating the growth hormone. They could have acromegaly. Acro is A-C-R-O, acromegaly. Anytime you see this word megaly, and obviously I need a better marker, megaly is huge, is big, way too big. Acro is your hands and feet, megaly is too big. So acromegaly, it usually goes along with giantism, things are just way too huge. That can occur when you have hyperpituitarism, an overstimulation of secretion of the pituitary gland. And the opposite of that is true too. So if you have less production by the pituitary gland, you can have dwarfism. So sometimes people who have dwarfism, they have a problem with their pituitary gland. It is an understimulation of the pituitary gland, so the pituitary gland is not stimulating enough growth hormone. So those are just some things to keep in mind, and there's more information in your book about if you have hyper or hypopituitarism, pituitary stimulation. So if you have too much ADH or not enough ADH, this is in the back of the thyroid, I mean the pituitary gland now. So in the front and the anterior, if that growth hormone gets stimulated or the ACTH or the TSH gets stimulated, that has to do with the size of the person, giantism, dwarfism, and then in Cushing's, we're going to talk a little bit more about Cushing's later on. In the back of the pituitary gland, then this is where your antidiuretic hormone is, your oxytocin. So if you have too much antidiuretic hormone, now keep in mind, if you will recall, your antidiuretic hormone acts on the kidneys. Anti meaning it's not happening, diuretic meaning you're not peeing. So antidiuretic hormone is also known as, I'm going to get a better thing, too much antidiuretic hormone is also known as SIADH. Remember we talked about that when we were going over fluid and electrolytes? So an overproduction of ADH out of the posterior pituitary gland will lead to a syndrome of inappropriate antidiuretic hormone. SIADH, syndrome of inappropriate, too much antidiuretic hormone, meaning you've got way too much antidiuretic hormone in the system. So what's going to happen to your patient? They are going to start retaining fluid. SIADH is when the body has too much of this hormone, and so they hold on to too much fluid when they should be peeing it out. So in this event, you can do some things like diuretics, but you'll just end up chasing your tail. What you really need to do is fix the problem that's up in the pituitary gland, because it is a pituitary problem that is causing an overproduction of ADH. And then, so this is overproduction of ADH, and the opposite can also be true. So this is when you're looking at the endocrine system, all of these things you can either have too much or too little, and both of them cause problems. So an overproduction of ADH leads to SIADH, syndrome of inappropriate antidiuretic, but not enough leads to something called diabetes insipidus, DI, and it's listed in your book, diabetes insipidus. What happens in diabetes insipidus is not enough antidiuretic hormone, so there's not enough hormone to hold in the urine. So these patients just pee out huge amounts of urine, lots of clear urine, and it's not like there's no glucose in it. The urine's fine. It's not a problem with the kidneys at all. So, the kidneys are still holding urine and still holding everything. It's just releasing a ton of fluid because there's way too, not enough antidiuretic hormone. So you're just peeing all over the place. And so the patient will be really, really thirsty. Let them keep drinking, otherwise they'll get too dehydrated until you can fix this problem. And again, both of these things are fairly common after somebody's had pituitary surgery. If they've had a head trauma and it's hit their pituitary gland, you can start seeing some hyper and hypo shifts in these hormones, which then cause an exact opposite response on whatever organ it's supposed to be working in. So that is pituitary issues. Most of the time when there's a not a malignancy, a tumor growing on the pituitary, most of the time they're benign. So if your patient comes in with a pituitary tumor, it has to come out surgically, but typically they don't need chemo or radiation afterwards. You have to follow them if they go into DI or SIADH. You got to kind of follow them and then deal with that. But most of the time it's just temporary, and the pituitary gland will kick back in. So so just make sure you know that stuff. Make sure you know anterior, posterior. The anterior does the female stuff plus ACTH, TSH, and growth hormone, and then the back of the pituitary is ADH, vasopressin, and oxytocin. So that's what the pituitary does. Now let's move down. Those are pretty much your three main endocrine organs in the brain. Now let's talk about your neck. In the neck, you have your thyroid, and it's this butterfly-shaped organ kind of right here. And when you're assessing it, hopefully you learned this from when you're in physical assessment, you stand behind somebody and you put your hands here and you have them swallow like that. You can feel that thyroid, but you shouldn't feel too much thyroid tissue there. When the thyroid starts getting overstimulated and growing, it's called a goiter. And you can see people will start getting a big neck there. Oftentimes that's related to iodine deficiency. Your thyroid needs iodine to work. And so people who are iodine deficient, and this is not that uncommon like in developing countries where they don't have iodine around readily. In the United States, not all, but most of our table salt comes with iodine in it. So when you're salting stuff, you just get enough iodine and you're fine. Most of us in the United States get enough iodine in our diet. But when a person is iodine deficient, right here, they can start developing a goiter, and this thyroid starts getting larger. There are some tests that you can do, and I think your book talks about it, doing radioactive iodine uptakes, where they will inject somebody with radioactive iodine, and then they will go in and get a biopsy of that thyroid and pull out a piece of the thyroid and see if that thyroid has taken up the iodine that's been injected. So if the thyroid is unable to take up the iodine, that's a problem, and then you have to figure out other ways to get iodine to the patient, and it could be indicative of a thyroid problem. So this that I started telling you up in the pituitary gland produces thyroid stimulating hormone. So if the whole point of the thyroid stimulating hormone is to stimulate the thyroid. So if for some reason your pituitary gland is not working and it's affecting the thyroid stimulating hormone, then you're going to see problems over here in the thyroid because you need this, then this in order to stimulate this. So it's this cascade effect. So your thyroid stimulating hormone comes down and stimulates the thyroid. The thyroid then produces T3, T4, and calcitonin. T3 and T4 are just their thyroid producing hormones. T3 works a little faster than T4. And they're responsible for the iodine uptake. Calcitonin is also produced by the thyroid. And what calcitonin does is when serum, and by serum I mean blood. Anytime you hear the word serum, S-E-R-U-M, that's the same thing as blood. When your blood calcium levels increase, and you'll remember normal calcium should be about 8 to 10. When those start increasing in the blood, then calcitonin is released from the thyroid. And what calcitonin does, it takes calcium from the bloodstream and shoves it into the bones. So that's what it's like. You know how insulin takes glucose and shoves it into the cell? Calcitonin picks up calcium and shoves it into the bones. So so you need thyroid stimulating hormone to stimulate the thyroid so the thyroid can produce T3, T4, and calcitonin. because you need calcitonin floating around, so when you get too much calcium, your body can deal with that. When people have non-functioning or ill-functioning thyroids, then you might start seeing an increase in calcium in the bloodstream. At the same time, you'll see like demineralization of the bones, because now the bones are not getting as much calcium as the bones are supposed to have. So the bones start becoming brittle, and you're losing calcium in the bones, and there's nothing to shove it back into the bones because of the calcitonin problem. If you have, and again, the same thing is occurring as if you have too much or not enough of the things that the thyroid is producing. So in this case, your thyroid gland, if it is not working enough, if it is hypoactive, if you have a hypoactive thyroid, you have Hashimoto's, or Hashimoto's is another cause of hypothyroidism. There's several causes of hypothyroidism, and I think I'm sure I saw this one on page, yeah, on page 1474 of your book, down at the bottom in this chart, 52.3. Yeah, 52.3. There's several causes of hypothyroidism, and one of the causes is Hashimoto's disease. That's an autoimmune disorder that causes hypothyroidism. And if your patient if there's any reason for hypothyroidism, suppression of those thyroid hormones, T3, T4, calcitonin, then you will see signs and symptoms of hypothyroidism. Hypothyroidism will cause things like fatigue, weight gain, thin hair, bulging eyes. They'll have higher T3, T4 levels. Lower T3, T4 levels. What else do you see in low thyroid? Basically, everything slows down. Weak bones. What else do you have? I'll look it up. The exact opposite is true in your patient who has a hyperthyroid disorder. In your patients who have hyperthyroidism, they have Graves' disease, Graves, Graves' disease. And Graves' disease, these people are very thin. Their hair is really wiry. They have exophthalmos, EXO, ophthalmos, meaning like bulgy eyes. They're usually quick and fast and hyperactive. They don't require a lot of sleep. They can't sleep because it's like being on caffeine constantly. They have way too much thyroid stimulating hormone, so they're just constantly like this is all the time. That is hyperthyroidism. That's actually fairly common. A lot of people will have this. So if you see somebody who's really thin, their hair's a little bit brittle and thin, their eyes bug out a little bit, probably need to get their T3, T4 levels checked because it might have hyperthyroidism. You do need to be cautious in some of these. Like, for example, you want to have these people who have hyperthyroidism, they should also not be taking stimulants. So you need to tell your patients to be careful with caffeine or stimulating things. The patients who have hypothyroidism, now you need to be careful when you're giving them like sedatives or agents that like if they are going in for surgery or something like that, you need to be careful because they might become overly sedated because their system is hypoactive rather than hyperactive. So you need to be careful with that. The Graves' disease, people have the hyperactivity, they can develop like cardiac arrhythmias. You treat hyperactivity, you treat with radioactive iodine usually. Sometimes it's just symptom management. Sometimes it's kind of like a chronic thing, and there's not really a cure for it, but you can do symptom management. Radioactive iodine is one. You can put them on some steroids. Sometimes will slow this down. Beta blockers will slow things down. So if you have a hyperactive thyroid, you're going to give medicines and you're going to do interventions that slow things down. If you have hypoactive thyroidism, like in Hashimoto's, you're going to do things that are going to speed that up. Like this person, yeah, you want coffee, you go for it because caffeine would be good to kind of help stimulate things. So in this one, you want to give medications that are going to suppress the production of the thyroid. And in Hashimoto's, you want to give things that are going to stimulate the thyroid. The one thing that's kind of funny about this is that everybody who's a little bit tired and a little bit overweight really, really, really wants a diagnosis of hypothyroidism because they want to blame something else other than them being overweight. But 9 times out of 10, the person's just unhealthy. They're just not taking care of themselves, and they're overweight, and so they get fat, basically. But you can easily tell because you can draw their T3, T4 levels, and you can find out if those are within normal limits and a person is fatigued and overweight, they're not diagnosed with hypothyroidism. They're diagnosed with obesity or, poor lifestyle choices kind of thing. So, yeah, so keep that in mind because everybody wants to have hypothyroidism and very little people do. Everybody wants to have hyperthyroidism so that they don't have to worry about weight gain and stuff, but that one's not as common. Okay, so then sometimes people can develop a malignancy on their thyroid gland, and that's why you have to go and get that physical assessment a lot to feel that thyroid gland, because you can feel if there's a nodule in there, and then they go and biopsy it and can determine that somebody has a thyroid cancer. That's a fairly easy cancer to cure. Typically it involves surgery, sometimes radiation following surgery, but usually it's a fairly curable cancer, especially if they get it early. But you can see because it's right here. So when somebody goes in and has thyroid cancer, they have to have it removed surgically. And now the nursing implications of that become very similar to a surgery, a patient that's had a head and neck surgery. You have to be kind of careful because it's near the airway. So post-operatively, you would lie the patient down just on a small roll under their head. You're not going to want to tip their head up because it's going to create airway problems. So just a little small roll under their head in a supine or maybe a low Fowler's position while they're healing. And then you just monitor that for bleeding and stuff like that. It's usually not a super high risk surgery to have. Again, you might want to have them watch their caffeine intake. You don't want to do anything that's going to stimulate this thyroid while they're recovering from thyroid cancer surgery. So you want to kind of rest the voice a little bit. But typically, if your patient is diagnosed with thyroid cancer, it's not the end of the world. We can treat that pretty well. Okay, the next endocrine system that we're going to talk about are the parathyroid glands. The parathyroid glands are these 4 little itty-bitty glands in the posterior region of the thyroid gland. So they're kind of embedded within the thyroid gland, and they're just sort of in the back. I think there's a picture in your book, except I should quit looking because every time I do that I'm like, oh no, there's not really a picture in there. Anyways, your parathyroid glands, these are really responsible for regulating your calcium and your phosphorus balance. That's the whole point. That's what the parathyroid glands do. They regulate the calcium and the phosphorus balance. So now here's the deal with, again, if you have too much or not enough parathyroid stimulant. So if you have high parathyroid levels over in here, if these start going up, you're going to have more calcium in the blood and less phosphorus. So increased parathyroid hormone, you're going to have more calcium and less phosphorus in the bloodstream. And this is because of increased calcium absorption from other areas like the gut, the bones, the kidneys, and things like that. You've got increased production of that because you've got increased parathyroid hormone, which is regulating that. So you're going to have higher levels. So what you want to do in a patient that has higher parathyroid levels is you want to increase their fluids. Obviously, you're going to restrict calcium. We don't want somebody who's already got high calcium to have more calcium, and that's easy. That's the dairy stuff. And here's the interesting thing. You do want them to exercise. If you are getting high levels of calcium in the blood, and this kind of goes along with calcitonin too. When your patient exercises, especially when they do weight-bearing exercises, when you exercise, it increases bone density and it will hold on to calcium. When your patient is just laying in bed or they become immobile, what happens is the calcium leaves the bone and moves into the bloodstream. So you need to be careful. In hyperparathyroidism, they have increased calcium, and you want them exercising, and by increased calcium I mean in the bloodstream. And so you need to get the calcium out of the bloodstream, and one way you get it out of the bloodstream and into the bones is by exercise. Another way is having calcitonin, because calcitonin is released when the calcium gets too high. Calcitonin is released. So hopefully, if this is hyperparathyroidism, hopefully you don't also have a problem with your thyroid. That'll release calcitonin, which helps get that calcium back in there. So those two things kind of work in tandem with each other. So some signs and symptoms, if you recall from fluid and electrolytes when we talked about that, your calcium, your signs and symptoms of calcium are all those muscle twitching things. So like if you tap on somebody's face and do that Chavadex, whatever you call it, sign where you tap on it and they're like going like that, or you put the blood pressure cuff on them and they start going like that, these are indications that you might have high calcium. If your patient consistently has high calcium, they might have a thyroid or a parathyroid problem. And you will also, the other problem with having high calcium in the blood is you can have things like renal calculi, meaning renal stones, nephrolithiasis, that's another name for kidney stones, with high calcium, because a lot of the kidney stones are caused by calcium. They can have nausea and vomiting, they can have constipation, hypertension, they can have cardiac dysrhythmias, they will have fatigue. All of those related to high calcium, low phosphorus. And then the opposite is true in hypoparathyroidism, meaning lower parathyroid stimulation. You're going to have just the opposite. You're going to have low calcium and high phosphorus. So again, you're going to get the muscle tetany, you're going to get the tension, you're going to get the twitching, the irritability. So once you start assessing those muscles, you're going to get that same kind of twitching, tightness, irritability kind of thing because of hypoparathyroidism. The other problem is if they have to remove the thyroid because of thyroid cancer, then you have to watch for these imbalances that can occur. And it depends on how much of the thyroid they have to remove. You can remove somebody's thyroid. You can do a total thyroidectomy, a partial thyroidectomy. And once they do that, then we have some drugs now, which are really common and they're very good, like Synthroid. It's a synthetic thyroid stimulating hormone. So even in the absence of an actual thyroid, you put a patient on Synthroid, and it's a thyroid stimulating hormone that helps regulate some of these the hormones that are released by the thyroid and the parathyroid gland. So if your patient is starting to develop hypoparathyroidism, some things that you can do is because they're going to have low calcium, you can give somebody calcium. You put them on calcium. This is when we want them to have dairy. We're going to throw milk and cheese at them. if it becomes too low and it's an emergent situation, you can start an IV and give them calcium gluconate. You can put calcium right into the IV. The other thing that you can do is if the muscle tetany is getting too much, you can put them on the same kind of meds that we put seizure patients on, like phenobarbital and stuff, because that suppresses the central nervous system, the autonomic nervous system, and suppresses those the muscle rigidity. So you can put them on drugs like that. Give them a little bit of vitamin D, calcium. Obviously, we're not going to have anything with phosphate in it, so we're going to be careful with their diet, making sure that they're not getting phosphates in. So that is your thyroid parathyroid lesson. Now we're going to move down to the adrenal glands. So your adrenal glands, if you will recall from whenever we talked about the adrenal glands, I think we talked about that. We talked about that with diabetes because of the cortisol. I know we did. Yes, we did, because I told you guys when your patient is under any kind of stress in the fight or flight response, and if you remember, like we talked about back up here, this is part of the autonomic nervous system that's totally responsible for the fight or flight, stimulate or suppress. And so all of these either stimulate or suppress. They're supposed to be in a nice normal window, but you know, your body will ebb and flow. So sometimes you want it a little more hyper, sometimes you want it a little more hypo. These conditions that I was telling you about, they're chronic conditions. They're abnormal. It's not like it goes into a hyper response and then returns to normal. These are chronically either hyper or hypo. So your adrenal glands get stimulated in the event of any kind of stress, any time that your body needs to fight or flee. Like, you know, if you're emotionally anxious, if you are frightened, if you're sick, if you have to go to the hospital, anything that's, you know, if you're taking a nursing test, those are stressful situations, and your adrenal glands, these little glands that sit right on top of your kidneys, get stimulated. Your adrenal glands are responsible for the catecholamines. The catecholamines are your epinephrine and your norepinephrine. So that's what these adrenal glands do, which makes sense. Either it produces everything to work really, really fast, or it slows everything down really quick. So the adrenal glands, there's these little tiny glands up here. You have a cortex, which is the outside of the adrenal gland, and then you have the medulla, which is the inside of the adrenal gland. But really, the adrenal cortex is the one that has probably more to do with the endocrine system, because this adrenal cortex here produces all of the glucocorticoids and the mineralocorticoids, basically the naturally producing steroids. So, and the androgens. So the adrenal cortex produces glucocorticoids, mineralocorticoids, and the androgens. Here's the thing. In patients who have prolonged steroid use, it can suppress the adrenal cortex. Herein lies the problem. So this is not your patient who is on a 10-day course of steroids. But you will notice if you put your patient on a steroid burst, so when somebody gets sick, or it's mostly when they're sick, you will come in and they will come in and you can put them on a steroid burst. So you'll blast them with steroids, prednisone, Decadron, you know, I'm trying to think of some of the others, methylprednisone. Those are all some steroids that you can put a patient on. Well, you blast them with a certain amount of steroid, and then you never, ever, ever just stop a steroid. It's not like, you know, you take your 10-day course of antibiotic and you're done. Steroids aren't like that. You blast them, meaning you give them a big initial dose, and then you taper it down. So like one day you'll have like 10 milligrams, the next day you might have 8 milligrams, the next day you'll have 6 milligrams, all the way down, because what you're trying to do when you blast somebody with steroids, it shuts down the adrenal cortex. And so, because then the body will recognize, oh, there's steroids on board, we don't need to produce any. The cortex doesn't need to produce any, so it doesn't. But what happens is some people that need really long-term steroid use, like your really bad asthmatics, you know, like some of the autoimmune disorders, and they have to be on steroids all the time, like your lupus patients and stuff, they're on steroids every day just to keep the inflammation down, and some of these autoimmune disorders. Well, what happens then is then the adrenal cortex is just like, yeah, I'm good, I'm out, somebody else is covering for me, and it just quits working, and sometimes it can never kick back in. So you need to be careful with your patients who are on long-term steroid use. So in a regular patient who's not on long-term steroid use, just regular, the cortex is going to produce your naturally occurring steroids, which you need, because steroids, as you know, when your patient is on a steroid, it will increase glucose. Every time your patient is on a steroid, blood sugar goes up. So you need to be careful with your diabetic patients. And anytime that the adrenal cortex gets stimulated, it releases the production of steroids, and it will, in the presence of the glucocorticoids, it stimulates the liver to produce gluconeogenesis, and then glucose is produced by the liver, and so you get an increase in glucose, which you want. In a stressful environment, a stressful situation, you need more glucose in order to meet the energy and the metabolic demands of the body. So you want that to occur. The problem then comes in if your patient is diabetic, or if the adrenal cortexes aren't working and you need that glucose, that steroid production. So anyways, this is what the adrenal cortex does. This is what they produce. Kind of read up on that. But again, you need to be cognizant of what happens when you don't have enough of these, or when you have too much of these. So again, when the androgens are released, when you don't have enough production by the adrenal cortex, your patient can develop a disorder called Addison's disease. Addison's disease, and look it up, it's in your book somewhere. I'm not even going to look it up again, because every time I say it's in your book, I can't find it, or I look like a complete liar, but I swear it's in there. So Addison's disease, your patients start getting like a rounded trunk, really thin arms. They can get like a buffalo hump back here. It's called a buffalo hump. It's kind of like this thing that happens back there. They tend to gain weight, especially in their trunk, but their arms look really thin. And in these patients, they should not be exercising too much. You don't want to have them exercising too much. Maybe gentle walks and stuff, but you don't want to increase their exercise. They can start having dark pigment to the skin. You might see them having low blood pressure, low blood sugar, low sodium, high potassium. They've got a lot of electrolyte imbalances. And so you need to keep these people on, keep them hydrated, check their fluid and electrolyte status a lot, because Addison's patients can develop a lot of fluid and electrolyte abnormalities. Watch their vital signs. They can go into something called an Addisonian crisis, and you want to prevent that. We do have some medications that help fix this. Sometimes it's a chronic condition. They just live with Addison's disease, so then we don't have a cure for it. You just kind of have to treat symptoms. If this goes on for too long, or becomes a chronic problem, they may have to be on lifelong steroids, because the corticoids are not being released at all, and you need some kind of steroid in place. You need some kind of glucocorticoids, mineralocorticoids, in order to reduce inflammation and make all the rest of these systems work. So you have to have some corticoids on board. And if you can't, then these people are on long-term steroids. And then you just know their adrenal cortex is never going to work, so you have to make sure they're getting cortisol every day. Or they'll run into some significant problems, like respiratory problems, cardiac problems, everything else. So Cushing's disease is increased in adrenal cortical activity. And when you have an increase in the adrenal cortical activity, it's oftentimes associated with a tumor up here in the pituitary gland. So the pituitary gland, once a tumor starts developing on it, you can all of a sudden see signs and symptoms of Cushing's disease. So then once your patient is showing signs and symptoms of Cushing's disease, now you got to figure out what part of the endocrine system is there a problem in, because it could be that they're having, a problem up here in the pituitary gland with the thyroid stimulating hormone, or the ACTH. That could be the problem up here, or it could be a problem down here in the adrenal cortex. And I think, once again, here I go telling you what I think there's I think there's a really good chart somewhere in here, if I can find it, where it shows how all of, on page, yay, look it, I found something. So if you look at page 1471, see down here at the, on figure 52.4, where it shows how, like, your neurotransmitters hit the hypothalamus, release thyroid stimulating hormone, goes down to the thyroid stimulating hormone, goes down to the liver, then subsequently goes down to the adrenal glands and the on top of the kidneys. That's why this endocrine system is a little bit confusing, but it's very intertwined. So one thing acts on the other thing. So if you see a problem showing up somewhere, like if your patient's developing Cushing's disease or Addison's disease or Graves' disease or something like that, you kind of have to figure out where in the system the process is occurring, because maybe they have a pituitary tumor, maybe they have too much thyroid stimulating hormone, maybe they've got like hyperparathyroidism. So you kind of have to do a lot of diagnostic work to find out where in the system the problem is. And then if you can fix the problem, like if it's a tumor or something that you can take out, great. If not, if it's a chronic disease or an autoimmune disease like Hashimoto's and we can't fix it, well, now we treat symptoms, and we may have to, put something on, a patient on like long-term steroid use or something else that's going to fix that. So I think that's all you need to know about the rest of the endocrine system. Let me just double check. I think that's it. There's some stuff I think in the back of this chapter that nobody's ever heard of. Oh, Cushing's, there's a good picture of what Cushing's syndrome looks like on page 1497. This actually, this person here, this is actually a female, but you'll notice in Cushing's syndrome, there's an increase in facial hair. There's a buffalo lump. If she was sideways, you could see this better, but see her shoulders kind of come down like this. If she were to turn around, this would be all like humped up in the back. That's classic buffalo hump that I was talking about. So do read up on Cushing's, and then this stuff in the back, like this aldosteronism and stuff, you don't need to know about that. You should read up on cortical or steroid therapy, because that's huge. Your patients will be on steroids, so you do need to know about giving steroids. But oops, I think that's it, right? So that's not bad. It's not that long of a chapter. It just gets a little bit confusing. But if you remember, hypothalamus and pituitary, basically your pituitary is the big one in the brain. Thyroid is the big one in the neck. Parathyroid is a little bit in the neck. The parathyroids, parathyroid, calcium and phosphorus. And then your adrenal glands, mostly responsible in the adrenal cortex. If you kind of understand this, that's it. That's all you need for endocrine, right? Okay, that's it.